Thank you very much. I appreciate the opportunity to be here and to reflect a bit, I think, on some of the themes that Dr. Faust has laid before us. I want to talk about this term personalized medicine. In part, we're here talking about genetic testing in children because of tremendous excitement about this idea of personalized medicine. There's a mantra, the right treatment for the right patient at the right time, and the underlying notion that has been talked about a lot, that really is the engine, I think, behind a lot of the perceived promise of genomics, is that genetic testing will get us there. Of course, we want to give the right treatments to patients, but the notion is with personalized genetic information, we're going to be able to do something that we haven't been able to do before. And I want to put that notion of personalized medicine side by side with a very different notion of personalized medicine that I think has to be within our thinking as we consider what genetics can do and what genetics cannot do. There's been a fair amount of research and reflection in the medical literature on what kind of medical care produces patient satisfaction. And it's quite clear when you talk to patients that what they want is care that attends to them as a person, that looks at their whole circumstance, and that includes their medical history, of course, but also their personal circumstances and personal history. And another, I think, important component of this way of thinking about good medical care is this notion of a working alliance between the doctor and the patient. The idea that they work together to figure out what's going to be, in fact, the right treatment for that patient. They work collaboratively because, of course, many actions that are important in support of health are actions that must be undertaken by the patient, and the doc and patient have to talk through those together, and they really need to like and trust each other. And I would argue that that is the vision of personalized medicine that we need to carry forward, so that the question is not really how is genetics going to give us personalized medicine, but rather how is genetics as a tool going to potentially enhance a personalized medicine that's based on trusting relationships between doctors and patients. I'm going to talk a little bit about newborn screening. I really appreciate Dr. Faust's comments that I think are very germane here. We like to show this simple diagram, and it looks both simple and wonderful, and represents, in a sense, an example of the promise, of fulfilling the promise of using genetics to personalize healthcare. It's extremely important to know, as Dr. Faust has walked us through, how hard it was to get to where we are now, how much we didn't know when we started, and how important it was to gather additional information about exactly how the test was going to work to find affected infants, and exactly what kind of diet was really going to help those who truly had PKU. Fortunately, a lot of that work has been done, and I think it's fair to say that we do have a successful program now that finds kids who benefit from a special diet and helps them. So if we take this broader view of personalized medicine, the one that looks at relationships, I think we need to reflect on the fact that even after we've gotten over all the difficulties involved technically in finding out what's the right test and what's really the right treatment, we have a whole lot of issues for kids with PKU and their family that have to do with the social circumstances. The fact that having PKU within a culture where most kids don't need the diet that kids with PKU have, and in fact won't do well on that diet, in a circumstance where the diet, in fact, is not a particularly attractive diet from a social perspective, what that leads to is that the care of a child with PKU is a far more complex matter and far more embedded in family relationships and doc and patient relationships than necessarily in the genetic testing that got the family and the child to that treatment circumstance in the first place. I think it's well understood now that if you're going to have a successful PKU screening program, you not only have to know how the test works to make it work right. You have to know the kinds of parameters that give you good sensitivity and specificity. You not only need to know what kind of diet you want to recommend, you need to make sure that the kids who need the diet get the diet. And what that means is that you're not going to have a successful screening program if you don't take measures to deliver the diet to those who have difficulty affording it. So, in fact, all the benefit of screening is lost if you can't do that. And the cost of diet is a non-trivial issue for many families. There are lots of social barriers to maintaining diet, and an important part of care given in PKU clinics is working with families, supporting families, helping them to develop strategies to support their kids. And ultimately, of course, kids grow up and have to take on management of their disease, and this is also a really important focus of good personalized care of kids with PKU. So, stepping back from that general point about personalized medicine, what we hope from the Human Genome Project is a huge wave of innovative healthcare that will improve healthcare outcomes. I want to reflect just for a moment that there are 3 different pathways in a general sense that we could get to that desired outcome. One of them is to test, to diagnose, or identify risk, and that's what we're talking about today, and I'll focus most of the rest of my remarks on that particular branch of benefit. As we do so, though, it's important to recognize that another way that we may be able to use genomic information very successfully is in the characterization of disease. We already have, for example, examples of gene expression profiles that help us to identify prognosis from cancer far more effectively than traditional methods of stratifying patients with certain kinds of cancers. And it's likely that molecular characterization of disease to allow us to look at and identify subtypes of disease for different kinds of treatment paradigms may prove an extremely effective use of genomic information, very possibly more powerful than the use of risk information. And then finally, of course, what we're all hoping for is innovative therapy. Ultimately, that's what we want, is new treatments. So when we think about the notion of genetic testing, and particularly the notion of genetic testing to personalized healthcare, I think we have to put it within this context and ask ourselves, how much can we get from risk assessment relative to other kinds of potential benefits, maybe longer-term benefits that are perhaps ultimately likely to flow from this technology? Well, we certainly have a few dramatic examples that say that genetic risk assessment can provide benefit. We have some successful newborn screening tests, as we've discussed. Here's another one. Medullary thyroid cancer is a condition which is caused not infrequently by a rare genetic disease, rare meaning 1 in 30,000, it's really not very common, called multiple endocrine neoplasia type 2. And the vast majority of individuals who have this condition have a mutation in the RET gene. And the important issue here is that individuals who have this mutation, who have this condition, have a very high lifetime risk of developing medullary thyroid cancer. It's not an easy cancer to treat. It can occur as early as childhood. With RET mutation testing, what we're able to do is identify in a person who has this cancer the condition, and then offer testing for the mutation that's present in the family member to other unaffected family members. So in the pedigree I'm showing you here, we have a grandfather who died of medullary thyroid cancer, and people didn't realize it was a genetic situation. His son develops medullary thyroid cancer, has the RET mutation testing, we find a mutation, and we can test his 3 kids. Each of them has a 50-50 chance of inheriting this condition. If they have the mutation, we can now offer prophylactic thyroidectomy, and although this has not been tested in a randomized trial, really for reasons of ethical concern that this was a beneficial treatment, we do have very good quality follow-up data now 5 years and more, substantiating what we had hoped to produce, which is a reduction in medullary thyroid cancer in kids who have this condition. So I think here's a good example. It's certainly a rare disease, but it's a good example of personalizing healthcare in a very beneficial way with genetic testing. We have a few promising examples in pharmacogenomics as well. Here's the dramatic one that's been cited a lot. We know that thiopurine methyltransferase activity is correlated with the likelihood of a child experiencing toxicity from thiopurine chemotherapeutic agents, which are routinely given in acute lymphoblastic leukemia. And as this slide shows, it's a very dramatic association. We now have genetic tests, and in some institutions, a standard of care that tests children prior to receiving these chemotherapeutic agents, because we have a good response. When the child has the mutations that are associated with low enzyme activity, we can reduce the dose of the chemotherapeutic agent and avoid the very significant adverse side effects. So there's no question that we have some examples that indicate that we can use genetic risk information as a tool that helps us to give better health care. What both of these examples emphasize, of course, is that there's a pathway from test to benefit. And that pathway has two important components. I think this really also reflects on the lessons of the PKU story that Dr. Foss told us. We test and we identify individuals with a positive result, and we need to know what that means. We need to be able to identify true positives. And then we take an action. And we need to know that the action we're going to take is, in fact, going to offer a health benefit. So I think the flow diagram that I'm showing you here is basically the hypothesis that we have whenever we have a genetic test that identifies a health risk that we would like to ameliorate. The task, of course, is to confirm the hypothesis by confirming the meaning of a positive result and confirming the benefit conferred by the action. As we do so, and as we look toward, I guess what I would say is the most articulated promise of the genetic version of personalized medicine, that is the notion that we'll be able to use genetic information to address major public health concerns, common complex diseases, not just people with conditions that occur 1 in 30,000 in the population, but as a general approach to healthcare for all of us. We have to take very seriously the spectrum of contribution of genetics to disease outcomes. We could put most health conditions somewhere along this spectrum. We have health conditions that we can see are mostly genetic, and I offer cystic fibrosis as an example of that. These are the conditions we call genetic diseases. Certainly, they're not entirely genetic. Other factors may modify outcome, but what you inherited in your genome is the major factor determining whether or not you have cystic fibrosis. Over on the other side, we have diseases that are mostly environmental, like chickenpox. In fact, there are a very small percentage of individuals who have a cell receptor change that means that they don't respond to the chickenpox virus, they don't take it up. But for the most part, this is an environmental disease. You get chickenpox based on your exposure to chickenpox. In the middle, that vast burden from a public health perspective of disease conditions are conditions that are affected by both genes and environment, diabetes and asthma just being a couple of examples. And we are now developing very powerful genomic research techniques, particularly now genome-wide association studies, that enable us to identify gene variants that contribute to those diseases. So we're in an era from the genomic research perspective of huge success in identifying all the genetic contributors in the middle part of the spectrum. That I think fuels a lot of anticipation about this notion of using genetics in personalized medicine. As we think about how we might do that, however, we have to acknowledge that most of the gene variants that are being discovered in these studies have a very low relative risk, generally a relative risk less than 2. Many variants associated with common complex diseases have relative risks in the 1.1, 1.25 range. So each gene variant contributes only a very small amount to risk. The genetic contribution to common complex diseases is polygenic, meaning many different genes contribute, and any given gene can account for only a small percentage of disease cases. Asthma offers an example. You can map what we know about etiology of asthma roughly in the diagram I'm showing you here. We have a number of specific genes that have been identified where variants within those genes are associated with increased asthma risk, or in some cases decreased asthma risk. The ones that I've named are fairly well characterized, but we have other data coming forward that suggest that there are likely to be 30 to 50 others. We also have very well established environmental risk factors. A number of them have to do with housing conditions or with environmental exposures that are clearly also associated with likelihood that a child will develop asthma. So within that context, we have to ask, what would genetics do for us in helping a child who might be at risk for asthma or helping a child who has early suggestions of asthma symptoms? How would we use genomics? What kind of test would make sense, and what kind of actions could we take after that test? What we're really getting at is, what is the way in which we could use genetic tests to help us to make clinical decisions differently so as to improve care of a child who is at risk for asthma. What we have to think about is not just the paradigm of a positive test leading to action with an improved outcome, and the need, obviously, for research to confirm that we're truly getting an improved outcome, but what's going to happen to the people who don't have a positive test and who then receive usual care or no particular action, depending upon the circumstances, and we need to be sure that they don't have any reduction in outcome. Do we want to only tell parents of children whose test is positive for increased risk of asthma that they shouldn't smoke? Obviously not. Do we only want to deal with housing conditions or diesel fume exposure for kids that we know to be at increased risk for asthma? No. So as we think about the potential for genetics to generate risk information, if we want to use it to improve health outcome, we have to think very critically about what we're going to do with that risk information and what the good or the bad of those actions are. As we do so, we have to confront the very limited discriminatory power of genetic profiling. I'm now going to show you a couple of examples from adult healthcare issues because I'm not aware of any robust examples for pediatric disease issues, but I think the lesson is generalizable. There have been several genes associated with increased risk for type 2 diabetes. I'm showing you data from 3 of them here on this slide. And there's a lot of excitement about the idea. In fact, one of these tests is already commercially available as a direct-to-consumer test. The idea is that you provide information about people's increased risk for type 2 diabetes, and then they can take action to reduce their risk. The actions, of course, are actions that we recommend for everyone: regular exercise, healthy diet. But quite aside from that issue, because there's the belief that maybe we could motivate people, I think we have to think about just how much the test is going to discriminate risk. And it turns out that the issue here for common complex diseases is the fact that they're common. And because they're common, and because the relative risks associated with gene variants that contribute to common complex diseases is generally very small, the result is that the discriminatory power, the ability to determine between who's going to get diabetes and who isn't going to get diabetes based on a genetic test, is extremely small. And when you look at that very small discriminatory power as shown on this slide, you realize that you want to be very cautious about crafting different messages for people who have a positive test versus people who have a negative test. Now, one response to that is that we could improve the predictive value of a test by testing not just for one variant, but for many, many different variants. There are probably 20 to 30 variants ultimately, we at least have hints of that contribute to type 2 diabetes risk. And so the vision is a profile, and that profile would allow you to find those people who are truly at high risk. And that will work, it turns out, but it's complicated too. I'm showing you an interesting diagram that comes from data on age-related macular degeneration. This is one of the common causes of vision loss in elder individuals in our population. And there's been a lot of excitement about genetics of age-related macular degeneration. We now have identified several genes that are associated with increased risk of age-related macular degeneration. And that data is exciting in part because it's confirming certain biological pathways that are important in the pathology of AMD. And we hope ultimately will identify innovative therapeutic approaches. In the meantime, though, there's this idea of genetic profiling. And what I'm showing you in this complex diagram is the result of modeling of tests for gene variants, for several gene variants in 3 different genes associated with age-related macular degeneration. This modeling was done by researchers who had identified one of these genes. And what they point out is that you can do a profile test, a test for multiple different gene variants associated with increased or decreased risk of age-related macular degeneration, and you can stratify the population. What you find is that a very tiny proportion of the population, 1%, have a greater than 50% risk of age-related macular degeneration, and actually a similar small percentage have a very small lifetime risk of AMD. The vast majority of people sit in the middle, a little bit above or a little bit below average. So even though you can use profiles to stratify risk, you have to think about how are we going to use that information. Well, first of all, what are we going to do for that 1% at very high risk? It turns out right now what we would do is tell them not to smoke and to avoid exposure to very bright light. Those are probably the most meaningful preventive actions that people can take. And it's not clear that we would want to limit those actions to that small percentage. It's conceivable at some point in the future that we will have a specific therapeutic intervention that we only want to apply in the case of very high risk. But if we get to that point, if we have evidence that an intervention is both helpful for those at very high risk and not appropriate for those at more normal risk, then we're going to have to decide how we handle the huge amount of information that flows from a test of this kind, how we handle the discussion with someone who's a little bit above risk or a little bit below risk. It's a complex issue, as I say, involving what does the test mean and what do we do with the test results, and clearly is a huge analytic and then communication task before us. As we go forward thinking about the use of genomic profiling in this way, we have to acknowledge a point that, again, I will just underscore points that Dr. Foss made, that we have huge data gaps. The point I really want to make is it's not enough to have the ability to do the genomic profile, which increasingly we do, which in the course of the next year or two we will be able to do for many, many common conditions. We need to know whether testing in fact leads to improved health outcome and by what actions it does, how testing would influence clinical management decisions, and that means the full spectrum of test results, and obviously what kinds of either direct or indirect harms might flow from testing, such as we've seen from certain newborn screening and carrier tests. If a benefit can be shown, if we find a test that can identify certain individuals who, if treated in a certain way, will experience a health benefit, we clearly have to look at benefits and harms and weigh them together. A lot of threshold drawing will be involved. Who do we call a positive? Who do we call a negative? What treatments do we guarantee to those we've called positive? And who participates in those decisions? who's around the table when we draw those lines. And then finally, of course, how do we assure that equitable access is assured? In thinking about these issues, we have a tremendous urgency, I think, to make sure that research is funded that will enable us to have data to answer these questions and not just speculation. And getting back to the first point, that data is embedded within a good understanding of care of the whole patient, that we're not looking in an isolated way at what the genetic test does, but at how the genetic test information is integrated into a much broader care of the patient and the patient's family. I will just, after Osler, say that as we think about this, if our goal is truly personalized health care, it's probably going to be much more important to know the patient who has the genotype than the genotype that has the patient. Thank you.